At this time, I would like to introduce our speakers for today's program, Dr. Benjamin Anderson. Dr. Anderson is Professor of Surgery and Global Health Medicine at the University of Washington and Chair of the Breast Health Global Initiative in the Division of Public Health Sciences at Fred Hutchinson Cancer Research Center in Seattle. He serves as the Director of the Breast Health Clinic at the Seattle Cancer Care Alliance. Dr. Anderson is also Vice Chair of the NCCN Breast Cancer Panel and the Chair of the NCCN International Program Steering Committee. He also leads the NCCN Resource Stratification Working Group. At this time, Dr. Anderson, I would like to turn the presentation over to you.
I am really pleased to participate in this NCCN webinar. I've been asked to address ductal carcinoma in situ. In talking about DCIS, it's important to recognize that there's actually been an evolution in the management of this disease over time. And so I'd like to touch on the history of this, talk about where radiation treatment fits, and then most recently about the 12-gene DCIS score that has been developed for this, and make some comments on what that data shows us. Let's begin with the history of DCIS management. Screening mammography has really changed the picture of ductal carcinoma in situ over time. The reason for this is that DCIS is best identified through screening mammography because of the formation of microcalcifications, such as these purple dots that you see on this screen. And it is because these calcifications show up on mammograms that we have this opportunity to identify disease that otherwise, prior to screening mammography, would not have been possible. Screening mammography really got going because of the HIP trials that were reported in the late 1970s that showed that screening mammography actually improved breast cancer outcomes. But what we can see is that over the 80s, as screening mammography was increasingly used, what increased was the rate of DCIS diagnoses and the rates of node-negative breast cancer diagnoses. Interestingly, many thought that the rate of diagnosis of more advanced cancers would decrease in a corresponding way, and that actually has not taken place. This helps us recognize that for more advanced stage disease, where early detection does not necessarily avoid late presentation, that treatment remains an important option. But in the context of DCIS, it's the randomized trials B17 and B24 that showed us about the management of breast conservation for non-invasive DCIS. In the NSABP B17 trial, women were randomized to lumpectomy alone versus lumpectomy with radiation. And in the NSABP 24 trial, after radiation had been shown to be beneficial in B17, they went on to do this randomized trial that compared lumpectomy with radiation versus lumpectomy with radiation and tamoxifen. And it is this data that has really defined the standards of care for DCIS. And that standard of care is that in general, women should be treated with radiation, not just lumpectomy alone. Because with lumpectomy alone, taken as a group, DCIS has high recurrence rates in comparison to the other groups. We can also see a benefit in the B24 trial to adding tamoxifen, although clearly the lion's share of avoidance of local recurrence has to do with the use of radiation treatment. So with that background then, we now recognize that lumpectomy with radiation remains an appropriate option for the management of DCIS, that we can treat women with lumpectomy with radiation, or we can treat them with mastectomy, in neither circumstance needing sentinel node evaluation. We do, however, do sentinel node evaluation with mastectomy in case we're wrong about the diagnosis and invasive cancer is found in the breast specimen. But this final group, there is a group where lumpectomy alone without radiation is considered to be a reasonable option. That's not the debate. The debate is whether we can actually find this group that is appropriately treated with lumpectomy alone. And that's been the nature of the argument that has gone on since B24 and B17 were published. It was the Van Nuys Prognostic Index, Silverstein et al. From Southern California, that really got this debate going. Through retrospective analysis of Dr. Silverstein's very extensive database of DCIS, they found that by using size of DCIS, margin width, and pathologic classification, that they were able to stratify patients into these different groups through this index. And what they found was that with women who had the very low indices based upon size, margin width, and pathologic classification, those are the Van Nuys index 3 or 4s, that actually lumpectomy alone appears to be a reasonable option. The reason being that prognostically, these women do extremely well with either with lumpectomy alone or lumpectomy with radiation. It's hard to make the balloon go up when it's already on the ceiling. And so they argued, using this retrospective data, that in fact lumpectomy alone can be used. It's a matter of finding those patients in an appropriate way. They also noted that margin width was an independent predictor of favorable outcome. But this did lead others to ask the question, should we in fact look at this prospectively to see if we could validate the findings? And that was this prospective single-arm trial run out of Dana-Farber, in which they took women with predominantly grade 1 or 2 small lesions less than 2.5 centimeters with a margin width of at least 1 centimeter to be treated with re-excision alone for ductal carcinoma in situ. And what they found was that they closed their accrual after 158 patients because the local recurrence rates were higher than were predicted and were excessive based upon their pre-study algorithm. So once they hit 2.4% local recurrence per patient year, which translated to a 12% 5-year treatment failure rate, they decided that this study should be closed. They found that 9 of these patients recurred as DCIS and 4 recurred as invasive. 10 out of 13 were in the same quadrant, suggesting that it really was a feature of local recurrence and not new disease. But importantly, none of these patients ended up having positive axillary nodes. And so this really was not a survival question, this was a local recurrence question. This led to the study that first authored by Kevin Hughes, published in JCO in 2009, of the ECOG 5194 trial. This was a prospective trial run from 1997 to 2002, where women with lower intermediate grade DCIS of limited extent, measuring less than 2.5 centimeters, or a high grade group of less than 1 centimeter, so smaller but high grade, and with margin width of at least 3 millimeters with no residual calcifications in the breast, they were treated with lumpectomy alone. And what they found was that there was a 5-year ipsilateral rate that for the lower and intermediate stratum was 6.1% events with a follow-up of 6.2 years, which is better than what was seen in the Farber trial reported previously. The high-grade stratum still had high recurrence rates with a 15.3% event rate at 6.7 years, suggesting that at a minimum it's only the low and intermediate grade stratum that should be considered for this. The way they compared their data was looking at contralateral cancer, since that is in essence an internal genetic control. And what they see here, the blue rates are ipsilateral breast recurrence rates versus contralateral rates, and you can see that there is a significant difference, but overall the low and intermediate grade lesions look more favorable. And this again argues that there is a group that can be treated with lumpectomy alone. The question is how to identify who those patients are. It was on the basis of this that a 12-gene assay was developed by the same group that developed the 21-gene assay used for invasive cancer. It's quite interesting to see how they developed their methodology. They had tumor blocks from the B17 and B24 trial, and they selected patients who had estrogen receptor positive cancers to try to identify from the original 21 gene score which of the genes might correlate best and be considered for a DCIS scoring system. And looking at that spectrum of genes, they identified these genes, progesterone receptor and these other circled genes here. And what these bars show us is that they were not affected by the use of tamoxifen. We already know that tamoxifen improves outcome for estrogen receptor positive cancers, so they were looking at those genes that were not associated with tamoxifen administration, but nonetheless had this same favorable outcome. And those were the genes that were used to develop the 12-gene DCIS recurrence algorithm. And when they used these in the 5194 validation series, used those 6 genes, they did find that there was a low rate group, this 230 patients, where the recurrence rates appeared to be less than 10% at 10 years. And this, looking at all ipsilateral breast events, this of course looked favorable. And the invasive cancer rates, which would be a subset of that, were also quite favorable. And this was used by the authors to argue that the score can be used to contribute to clinical decision making. They suggested that it does quantify ipsilateral breast event risk and invasive breast risk, that it complements the traditional clinical and pathologic factors in improving individualized treatment strategies. But there were criticisms of this application. It was noted that the ECOG 5194 validation series was very restrictive in that it was very small lesions that were looked at. It was noted that the high-grade stratum was underrepresented, and so it really wasn't reasonable to talk about the high-grade DCISs. And therefore, the more extensive and high-grade cancers, it really wasn't known yet what the 12-gene assay would report. So at the San Antonio meeting this past December, a new series was reported based upon the Ontario Provincial DCIS cohort analysis. This was a much larger series of Canadian patients between 1993 and 2003 who underwent, a subgroup of them underwent breast surgery alone without radiation treatment. Their objectives were to test the assay to see if the outcomes would be similar in measurement. When they then looked through this entire series and identified those patients where they had tumor blocks and adequate follow-up, they came up with a series of 571 patients who had breast conservation surgery alone and negative margins with tumor blocks. It was notable that this had better representation of high-grade disease than what was seen before, and also included larger lesions than just the ones that were seen, with a significant fraction more than a centimeter in size. And what they found was that overall, the low-grade stratum, 12.7%, had ipsilateral breast events at 10 years. Of that 12.7%, 8% were invasive cancers, and 5.4% were DCIS. And so what this does is it supports the conclusion of 5194 that in fact there is good correlation between this assay and local recurrence rates in those patients treated with lumpectomy alone. It's very important to recognize this does not tell us about the effect of radiation treatment. All it's doing is identifying a low-risk group. It is notable that the DCIS score appeared to be independent from other factors statistically in multivariate analysis, comparing it against tumor size, patient age, tumor subtype, and multifocality. All of this favorable. So in summary, there is increased use of mammographic screening that has led to DCIS rates rising from 2% up to 20% in the United States where it stands today. Breast conservation therapy with lumpectomy and radiation has been shown to provide adequate local regional control of disease, and there does appear to be a subgroup of DCIS patients for whom lumpectomy alone provides adequate local regional control. The group exists. The question is how to identify them. The Van Nuys score is a retrospective analysis, but it was not validated in a prospective series. But we do have this DCIS score, which may improve on identification of a low-risk group. But of course, it does not make a statement about the impact of radiation treatment. It is a prognostic rather than predictive assay. But it is notable, if one uses this assay 12.7% of these patients treated with lumpectomy alone in the low-risk group will be predicted to have an ipsilateral breast event, and 8% of them will be predicted to have invasive cancer. And it's really up to the clinician and the patient to decide, is an 8% invasive cancer rate really low or not? We need subsequent data.